And should
Okay.
we go backwards this time just for fun?
Okay. Jason Chan, radiation oncologist, primarily a clinician. Okay.
Brittany Dingler, Senior PA in Medical Oncology, working with three other APPs and two attending physicians, Dr. Alghazi and Dr. Kong.
Mary Shu, one of the head and neck cancer surgeons, probably a team about 8 to 9 head and neck cancer surgeons.
Hi, I'm Sky Yang. I'm a speech language pathologist specializing in voice and swallowing. I love to eat and I love to talk. So thank you for having me here today.
Amazing. Thank you. Thank you for your flexibility, you guys. And one thing for the audience, I'm happy to collect questions. So you have a pad of paper. If there's a question for the panel that you would like to submit, please feel free to write something down and I'll have our lovely med students come and collect. So the first question that I'm going to throw out to our lovely panel, how do you work together as a team to ensure our patients receive the best care? Because we obviously come from many different departments. So there's a lot of communication that has to happen. So tell me sort of what your guys' process is.
So I can start since I'm holding the mic. So for the SLP team, we are integrated in the head and neck surgery team, and we have half of, well, it depends on, it varies in terms of schedule, but half the day or full day on clinic jointly with the head and neck surgeons. So folks who are coming in to see Mary or their surgeons, they may or may not get a bonus visitor from someone like me or Kara. So that's like our daily workflow where we are integrated into the team pretty early on, even sometimes the day of diagnosis, which may or may not be the most appropriate time to talk about rehabilitation, but it is a reminder that throughout this journey, there is someone thinking about their function and their rehabilitation very early on and talking about outcomes and rehabilitation potential even from the onset of diagnosis. And then we also attend radiation oncology meetings and tumor board discussions on a weekly basis. So we hear updates as folks go through treatment. And then post-operatively, if you're already plugged in with one of us, we have our surveillance program called Swallow Watch, where we follow and integrate timed tests for your swallowing outcome to kind of follow you ongoing, and surveys that you might find in the mail so that we can kind of keep track of your function.
And to add on to what Sky was saying, I think a couple of formal ways we all meet and see each other regularly. Every week we have tumor board, as Sky mentioned. Tumor board may be very familiar, but for those that aren't, it's I tell patients it's a room of like 20 brains that get together and think about your care, and we try and make sure that your treatment options are the best that we have. Or the best options, and you have all of those in hand. So it's one way we meet in person and hybrid online once a week. The other nice thing that we're really lucky to have is that in our clinic, we're actually just very close to each other. So like Sky and Kara are literally in our clinic. So when we see patients, we're like, oh, I think they could come and it would be super helpful if you can come and see them. Dr. Hall and the team, and with Dr. Kang as mentioned, we also have the dental oncologist actually in the clinic, which is very unique. I think it's maybe like, only one or two within the Bay Area that has something like that. And then Brittany is just down the hall. So sometimes they'll be like, so-and-so didn't get their chemo med-onc appointment. So I'll just walk down there, just poke my head in and see if Brittany or Dr. Alghazi or Dr. Kang are there. So yeah, I would say that we meet regularly. We are co-located in clinics. And the other nice thing, building on what Brittany said before, is like I also really enjoy the team we work with. Sometimes I tell patients, I don't know if your ears are burning, but there's been a lot of emails about you behind the scenes since I last saw you, because as providers, we're constantly like messaging or emailing and coordinating with all the different providers. So it's pretty, and people respond very quickly when it comes to patient care. So very lucky to have a great team.
So maybe I'll add that we have very patient-first surgeons, I would say. So I don't know how. I guess I don't have much frame of reference, but it is really helpful for us because as radiation oncologists, we're oftentimes downstream of a lot of the process. Sometimes if things aren't set up ahead of time, then the whole process just lags. But usually when patients first establish care with our surgeons here, regardless if they get surgery or not, our surgeons basically galvanates, all the different like dental, um, nutrition, and SLP, and all the different services. So, and that's regardless if patients ending up receiving surgery or not here. So I feel very fortunate. That's pretty unique.
Great. My next question is, what's one piece of advice you wish every patient knew at the end of their treatment going into survivorship? I mean, that's hard.
I want to give a global bird's eye kind of overview in one or two sentences before I kind of start answering this. So I've been doing this for about 6 years, being a PA in medical oncology. Before I came to UCSF, I was at a community oncology clinic. We saw all hematology and oncology conditions, which is very overwhelming, and we had very few resources. We did not have a speech language pathologist. We did not have a registered dietitian. We never saw in person the radiation oncologist, and it was very hard to get in touch with them. We put feeding tubes in every single patient who got radiation to the head and neck because we didn't have any other resources to figure out what to do if it got to be a situation that was dire. So we tried to anticipate and use what we had. And so when I came to UCSF, being able to work with all of these people who had no problem with me calling, texting, emailing, going in person, I understood why there is so much literature that tells us that being treated for head and neck cancer at an academic institution with all of these resources leads to better outcomes. So that's my global overview that I get excited about. And then the survivorship part is that since medical oncology, like I said, post-keynote trial is being used more and more early in the surgical process, I really try and get patients thinking early about what does quality of life mean to you, whether this patient has a chance of cure or this patient has a probably no chance or little chance of cure, but we're doing everything we can to give them as much quality of life for as long as possible. We start those conversations early and we plug them in with the symptom management team, which is the palliative care team, so that we can make sure that we're doing everything that aligns with their values, their needs, the time they want to spend with their family and how that looks for them. So that as we continue through the treatment process surgically with SLP, do they want a feeding tube or do they want everything they can possibly do to avoid a feeding tube, and what would that look like for them? And what does immunotherapy versus chemotherapy, if we have a choice, look like in regards to their quality of life? That is how we address survivorship early on. And we do it as soon as possible from day one. And my patients tell me that I'm dramatic because I make them thinking about these things early on, but then when a bad scan comes through, they know what they want the next steps to look like.
I really like that answer. I would add to that, one thing I think about is that as a physician, I love hearing from patients and families like what they want. And I want patients and their family members or caregivers to be advocates. Like I say, we're in many ways partners. And so I tell patients, like, if you have something that comes up between now and when I see you next, please just message us. Let us know. We're here for you. Don't wait to come to us. And I know sometimes it's, things, people are busy. Things may not always get in on time. And so I say, don't wait for us. Just please come to us if anything you feel like needs to be addressed or falls through the cracks at all. So I think to add on to Brittany, I would say that I always tell patients and their caregivers, like, please advocate. We're here to help you, and we're working together to make sure that you have a good quality of life and you get to the goals that you want.
Those are both amazing points, and I took a lot from that. So thank you. One thing I do hear from patients, first of all, I think the panel earlier today before lunch, I learned so much from that too, just hearing from patients. But as a speech language pathologist, we're seeing and counseling and working with people in different points in their care. And I think one thing in terms of moving into survivorship, I hear patients talk about a lot is the disappointment that they feel, where like the trajectory of healing or recovery isn't linear, and or it's taking a long time, or the recovery period, it's like, oh, I felt this gain and now it plateaued, and then now it's a dip, or it's so unpredictable. And I think setting that stage, like the recovery from surgery is very different than recovering from chemo radiation. And so setting that stage in terms of like that next steps of healing, it's not going to be linear. It might be cyclical. It might be like a wave, and it's hard to predict. We try our best to educate and prepare and all the science that this, not like we're trying to contribute to, like Dr. Yam was sharing earlier today, like learning so much, but also it's hard to predict everybody's individual course of wavy recovery. And so I think that resilience in going into survivorship, knowing that things will change, that's a guarantee.
Okay. Checking in with the audience. Does anyone have any questions they would like to submit at this time? Okay. I'm just going to repeat the question for the audience. So the question is for, I'm assuming the X-ray swallow test. How often are patients getting those? And then
is it Swallow Watch?
Swallow
the
Watch?
surveillance program? Yeah.
Oh,
yeah.
What have we learned from our Swallow Watch program?
Yeah. So that's a study that all of the SLPs here are involved in, and we do annual X-ray swallow evaluations. It used to be like for first 2 or 3 years, but now it's been extended to the first 12 years after treatment. It's just a long time, which is a good thing because people are meeting that 12 years. But if you've given us 2 stable swallow studies, we do get replaced by a survey, and the way you answer that survey will tell us when to pull you back in for a swallow study. I think the data on that, the Swallow Watch program, Kara's going to have to help me out on this, because I know you did a presentation on this before, but there is a dip in the latent period of like 7 years.
Oh, you're talking about like
Swallow Watch?
Yeah. So basically what we've learned so far from the data that we've collected with our modified. So we do modified barium swallow studies. We take what's called kinematic measures. So I literally sit at a computer and measure how much each muscle in your throat moves when you're swallowing, because that gives us nice objective data. And it catches like subtle change over time. So what we see is like the first, from your baseline to like, you'll have like a slight dip in the first 3 to 6 months, and then you'll have improvement that 12-month X-ray test. And then we start to see a slight decline in the 2 to 3 year.
I think there's a plateau period, right?
Yeah,
there's
it's that first 2 years. And then after the second year, we start to see a decline.
Yeah.
And I say decline in a way, it's like a spectrum, right? Mm-hmm. So like some people have more of a decline where they're more symptomatic, where they're like, oh my God, just things are sticking in my throat. Or it's just like like where it becomes like a bigger problem. And I think then we start to see, as the years kind of go on, more of a decline in certain, what we call kinematic measures. So like the throat's ability to kind of squeeze, to push things into the esophagus and the stomach. Yeah.
And from the exercise perspective, earlier the better, the more change we can make, or we as a whole collective, universal, and with the guidance of swallowing therapy. Later on, the goals of therapy might be a little bit different. It's not going to be intensive exercises or stretches, because it may be just the landscape in your mouth and throat has changed so much that we have to navigate around and find ways to compensate to meet those quality of life goals.
Yeah, I was just going to add a couple things. So I learned a couple things. The first thing I learned is that I think surveys are actually quite useful to send out to patients. And we're increasingly sending out surveys to patients. And it's always a question of, is it too burdensome, et cetera, et cetera. But having some standardized way of keeping track of how patients are doing, I found it was actually a lot more helpful than I thought it was. I thought it was going to be a huge burden. It might be a burden, but it's actually very helpful also. The second thing I learned is that it's very helpful for us to have some way to know how a patient is doing outside of the usual structure of coming in every 3 to 6 months. So for example, this is unrelated to the Swallow Watch idea, but for example, one of my colleagues in my department is handing out Fitbits to patients to try to keep track of some things you can collect from that you wouldn't otherwise know about. So those are the two things that I got from Swallow Watch.
Great. That actually leads up into my next question. Oh, sorry. Okay, and then I promise you're next, Carrie. How often do you want to see patients, once they're done with treatment? So what should follow-up look like? In this first year up to 5 years potentially?
So I think if you poll all of us independently, you'll probably get slightly different answers. But I would say in the first 2 years, maybe every 3 months, and then from years 2 to 5 after treatment, every 6 months.
Say I agree, and obviously more often as needed. But yes, I agree with Dr. Chan. Maybe can I add something else from the Swallow Watch study, which is a great question. I think one plug is, as a team, as Dr. Yam mentioned, we're always looking for ways just to improve patients' and caregivers' life and experience, especially for this group coming out on a Saturday for this event. If there are ideas that you all have that are particularly like, I wish this part of my experience was better or whatnot, I think we would all as a team love to work with any of you to get your perspective on how we can improve patient care moving forward. So some of the projects that we're starting to think about is integrating dental preventative care, thinking about delays to care, thinking about depression with going through these experiences. And I think as a team, maybe just plug if anyone's interested, would love to work with you and also get your perspective as we as caregivers or providers think about doing studies moving forward.
And then Carrie, you had a question.
Yeah, I think that's a great question.
Mary, do you mind just reiterating?
Oh, yeah.
Yeah, just for
Okay, how
the,
do I-
I'm happy to too.
Go for it if you
Oh,
have.
okay. I'm going to try my
Good
best, Carrie.
question.
So it seems to be the question for the whole panel is how can we like coordinate as a group to help with maybe optimizing patient outcomes and potentially preventing certain symptoms or long-term side effects that may impact people later on.
Yeah,
Did I-
and then also like, are there other innovations within other departments that we know about that can help improve quality of life? Yes, that's a very good question and very complex question too, but very good. I think the two thoughts that come into my mind is one concrete example, and then one thing that I've been toiling with a bit on my mind for a while. So the concrete example is dental care. So we all know that like dental care is really challenging to access. I work here and also at San Francisco General Hospital, where the patient population has a lot of, with Dr. Shannon, have a lot of barriers to care, and dental care being a huge issue. So in the Bay Area, like 3% of dentists accept Denti-Cal, which is what people on Medi-Cal can actually access. So almost like all our patients there don't have dental care access. So one of the nurse practitioners we work with, Shauna Brody, she came up with the idea of like, in pediatric offices, they're like applying fluoride treatment to these kids. Like, why don't we just do it in our medical offices? Because we see patients every 3 months for a couple of years afterwards. And so we have started kind of under her idea, we've for the past year been starting that study at San Francisco General Hospital and starting to think about how do we integrate preventative dental care into medical care, because currently the US, for some reason, we don't consider dental care medical care. And so some of the things that we're starting to think about as a team is like, Dr. Kang actually had the idea, should patients go home with fluoride and just apply it on themselves? Like, would that be effective? And we're going to be reaching out to the dentists and dental providers around our community to ask them about how do we improve dental care access for head and neck cancer patients, because many dentists don't feel comfortable taking care of patients after they've gone through head and neck cancer. So that's something like more concrete. And then one thing I've been kind of like thinking about and actually talking to someone earlier today about in the US and also internationally is just delays to care. I think every healthcare system, it just like frustrates me that every healthcare system has delays to cancer diagnoses and like treatment. And that's an area of study that we've started to kind of look at UCSF, like what does time to care look like across a whole care continuum? What does it look like at San Francisco General Hospital? We're starting to talk to patients at San Francisco General Hospital to see what they think about delays to care, but that's like an area that I think it's probably like a big picture problem, but would love to get patients' perspectives and help on that too.
I'm looking at Sky because I made her let me shadow her for a full day or maybe two last year, so I could understand what she's doing on a day-to-day basis. So when I ask for her help, I know what I'm asking for because I ask a lot. And so one thing that I think has been really valuable is one, to know that both Sky and Kara do a lot of lymphedema intervention and education in their clinic. And so that has been really important because, as you had mentioned, knowing as much as you can early on, but then also knowing what you need to continue doing, what frequency, what's best for you is so important, because I think Dr. Yam had discussed what can happen down the line. But what I notice most often is when patients have finished their chemo radiation and they're still coming in to see us either for surveillance or because they're getting immunotherapy afterwards. And so I see them every 3 weeks, for example. I might start to notice changes in their neck, things that are starting to become more firm, for example. And I check in saying, are you still doing those exercises that you would talk to Sky and Kara about? And what I find is a lot of patients will say, well, no, I don't really do them anymore because I'm with treatment, or no, I don't do them as often because there's these other things going on. And so making sure that they're still plugged in with the SLPs they're supposed to see and at the frequency they're supposed to see them is really important. And then also we have the St. Mary's Lymphedema Clinic. And so when appropriate, we also make sure we get them there, and that allows for access to care if they're not able to only see Kara and Sky, for example. And then the only other thing I'll say, just because it's important, it's a little bit off of what you had asked, but patients who have head and neck cancer can also have other cancers, especially, for example, patients who are veterans with exposure to Agent Orange often have more than one cancer if they have head and neck cancer. And so pushing them to continue the appropriate screenings, either at the VA with their primary cares, is critical, because if you are somebody with HPV positive or pharyngeal cancer, you know, as far as we believe are cured, and then we miss a colonoscopy, we miss prostate cancer screening, that's going to be really important, because getting a second cancer that we could have prevented on screening is important for quality of life. So I always like to bother people with that, because they roll their eyes at me saying, why do I have to go get a colonoscopy when you just made me do 7 weeks of chemo radiation? But that's why. So
the question is, what do I wish other in the maybe upstream or downstream in another department would be doing more efficiently, or my department? Sorry, can you repeat the question? I just want to, yeah. Mm-hmm. Yeah. 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 Mm-hmm. Downstream, or just in the patient. Yeah. Yeah. So I think about, from the world of voice and swallowing, I was thinking about this as everybody was talking. You know, I think that education, because the throat area is responsible for so many functions that are automatic, right? We don't really think about it until something goes wrong. And so I think educating people on what might a swallowing disorder look like or feel like, or what might it present with. And it doesn't have to be cancer related, right? It's just the idea of the mechanics of what swallowing is, what areas of the brain it might be impacted, how it can, the throat, what parts can't you control, automatic, and what parts can you control, and mindfulness, and how to integrate what Dr. Goyle was talking about earlier today, and like thinking about the throat and think about swallowing in a way where we kind of parse out, these are things that you potentially can change, these are things that we don't have. And I think about this from like, even from like a first patient just got their cancer diagnosis. People may not be prepared to think about all the elements of cancer care and recovery and so on and so forth. I do like to think about like bringing attention and mindfulness into the throat. What areas can you let go? And what areas can you control and create pressure? And how that changes throughout the day. And so that, I think about that from like just SLP and what we can do. I also have lots of thoughts on delays in care. That was my first thing that came to mind when you were sharing. And, you know, Kara and I are 2 SLPs in the head and neck cancer department. St. Mary's also has amazing resources, but it's hard to keep up with the volume.
If I had to brag about our program a little bit, I would say that we are not very siloed. I mean, there's always work that can be done, but I would say compared to maybe a lot of other places, we do have a good understanding of what each other does. So, you know, this could be a whole topic of its own, but if I could just give one example with dental, at a lot of places, you know, there is something to be said about doing everything at one place, because a lot of times patients would come and say, like, I saw my dentist already, I'm ready for radiation now. But there's a lot of nuances with these kind of things. So for example, our dental oncologist here, basically, even before we even treat a patient, wants to know roughly how much dose every single tooth on a patient is going to be exposed to. And it's not just about extracting a tooth or not. There's all kinds of little things that I had no idea that was part of their thought process until we just started managing a lot of patients together. So maybe I'll give a plug to places where all these different services are in one place. And yeah, and to your point, it is very important not to be siloed because so.
Great. Any other questions from the group? All right. I am going to close with my last question, which probably is going to be a doozy because I like this. So how do you help patients cope emotionally with the changes following treatment? You know, because I know for the patients that we see, it could be a lot of change very quickly. So how do we help support patients through that process?
Yeah, it's very tricky. I actually built before you asked your question, Kara, one thought that came up to Carrie's question was actually I was also thinking that mental health is actually a huge component of this whole experience. We know that depression is among all cancer types of cancer, head and neck cancer patients have the highest rates of depression, and also unfortunately suicide as well. And I think we also can't forget how much burden it is for caregivers too. That like emotional toll is so challenging, and also just to see someone you love like suffer is like incredibly challenging and feeling like helpless sometimes. So yeah, I think the emotional aspect of this and anxiety, waiting for scans, like all of that is just such an emotional roller coaster. um I would say that in individual patient care, when patients are going through surgery, I always tell them the first 2 weeks are definitely the roughest. And usually, if the more like active and someone is, and like it's going to be much harder because you're going to go from your life to like sitting in a bed for like a week sometimes. And just to try and mentally prep patients for that change. I think we're really lucky, as Dr. Chan said, we have fantastic symptom management group here that will help patients if if needed with depression, et cetera. But it definitely is I think it's a very challenging component of going through this. And I think we as providers also like sometimes feel that of what patients are feeling. And we also will like rely on each other to be like, hey, so and so is really struggling, and we'll talk to each other and figure out, okay, let's get them to symptom management and whatnot. But I would say a couple of takeaways I have is like one, when we talk to patients, we try and prepare them as much as possible, but there's obviously nothing we can ever say to really prepare you for what you go through. And we will never understand like what you as patients or caregivers go through, but we try and as much as we can. That's number one. I think the second is I've seen that having social support is just such a vital part of this whole experience. We see patients that have like such loving family, caregivers. We also see patients who don't have like anyone to support them. And it's so challenging. That whole emotional adaptation piece of it is so challenging when you don't have someone there to support you, to push you, to nudge you, to bring you to appointments, just be like, hey, what did that doctor say? Just that extra like person near you. So I think, when we can, or we see patients without like family, we try and see, okay, who's in their team? Like, who do you have in your community that can help you out? And I think one last thing that we're trying to figure out too is, like, as mentioned, depression is such a big part, even among people who have never had depression before going through such an experience. And there's people who've studied that among people who don't have depression, if they take antidepressants, they actually have better survival after head and neck cancer care. But there's a lot of challenges with like having that prescribed. Like, obviously it's like giving antidepressant, it doesn't come without side effects and whatnot. So I think one thing we're trying to think about is like, how do we integrate that into care, or the mental health aspect a little bit better into care long term.
The last point actually that you made reminds me. So we actually only have one FDA-approved drug for chemotherapy neuropathy, and that is duloxetine, also called Cymbalta, which is an antidepressant, anti-anxiety. So it is interesting that that allows for an easy segue for folks who may not have been as interested in talking about mood, mental health, emotional well-being. We start having conversation about, well, this is a physical symptom you're having that you want help for. It also provides this other help. How are we doing here? Would you be interested in something that might, if you are feeling, depressed mood at times, do you think that that might also be something of value to you? And seeing those patients be a bit more receptive to going down that path of treatment because we're addressing their neuropathy it's always interesting because it does end up helping in a lot of other ways. And there's no tricks involved. This is what it's primarily for. That's an issue for you that you want treatment for. It may also do this. And so that's something I actually really enjoy because it can be really hard to get to that place where we're talking about how can we directly address head on your depression, your anxiety, other things that are happening. And then the other aspect that I would say is that a lot of patients who have a really big support network at home come by themselves every time. And I have patients I've treated for years who I've never met their family, their friends who I know are really wonderful and supportive. So from the very first appointment, I say, who do you have at home who would call us if there was a problem, or who would call 911 when there's a problem? Like, where's kind of that hierarchy of people that if you really are sick, will step in for you. But also I say, I really like answering questions. Bring me a list of questions that they've been asking you because I know they've been asking you questions. And that helps because I think the uncertainty component of going through treatment, again, whether you're there for cure or palliative treatment, that uncertainty, as much as we can reduce it, is going to help with the overall anxiety and feeling of well-being. And so that uncertainty either can be, here are the awful side effects and when you'll probably have them during chemoradiation, and we're very honest, so when they happen, it's not a surprise. Or it's, what have your friends and family been asking? And I will do my very best to answer because there's a lot of really well-meaning family members and friends who will find certain things online. You need to take this bucket of supplements because that's what's going to help you cure your cancer. You need to go like fast for 4 days, like things that I've heard that I think are coming from a good place. If we can address those and answer it in an evidence-based way so that the patient not only has the information for themselves, but then feels better about being able to go home to all their anxious family members and give the information. And I encourage them to have the family or friends call me if they feel comfortable doing so that we can just reduce that amount of stress that often patients don't feel like they can bring up.
You mentioned something about that unknown in terms of treatment and outcomes. And I think about what Dr. Yam said earlier today, which is the body wants to heal itself. So even when I was talking about lymphedema, I mean, our body, I feel like part of the journey throughout this cancer care is learning how to trust your body, because there's so much of it that you don't have control over. And I don't pretend to know what it's like to go through cancer, but there is probably, from what I hear, seeing my mom go through it, it's like there is that fear of the unknown. And like every time there's a scan, like holding her breath and not knowing if I can relax, like, where my mind goes, from what she tells me, so it's like there's a level where that it's a journey of learning how to trust you in your own body, even though you have no control of cancer cells, cancer mutations, like that's out of your control, but you are the expert in your body and how it feels, what you're thinking about and what you're experiencing, and sharing that with your providers like myself, and for us as providers, seeing that as truth, feeling that, knowing that that's truth. It's not just from, oh, this person's anxious, right? No, they're telling you something because it is their truth and they are the experts in their own body. And I think giving patients more ownership in their cancer treatment and recovery it helps us be better providers. And I think that participation. So like even like something like this, learning about different perspectives, including people who've gone through it.
I guess I'll say two things. One is that there will likely be more surveys coming for for you survivors, um, and hopefully that will answer some of your questions. Because only by being methodical about it, you can see yourself like whether you're in the middle of the pack or on one of the extremes. So that's one thing that we hope to achieve. So it's not just a laborious exercise to make people's lives difficult, but we're hoping that eventually we'll collect some numbers and be able to tell you exactly where you fall within the spectrum of patients at your stage of follow-up. So that's number one. So please be open-minded about surveys that come your way. The second thing I would say is that there very likely is a patient that between all of us on the board who've gone through a similar experience. So I've heard that most patients when they come through this forum from through the support group, they'll find people who've gone through that experience, but not always. Some people say I just don't seem like I'm kind of off the side. I don't see a similar experience here, but you could always contact one of the people as part of your treatment team, and then we'll find you somebody to talk to. So a lot of times we've had so a lot of times I guess I can't speak for everybody, but I've tried to find like a one-on-one person to talk to.